right, welcome everybody to our week 3 lecture. I'm going to go over rural healthcare, vulnerable populations, and drugs and alcohol. So we're going to do a lecture I'll cover with the PowerPoints again, but initially we're going to watch a video that's just going to show us a little bit about rural healthcare. So I'm going to do that with us. Okay, so we're going to take a look at this video here.
If a man has a heart attack in Horton, you might well be dead.
It's been over 2 years since the hospital in Horton, Kansas closed. After years of financial problems, it finally went under. At the time, the closure left folks like the ones at this senior center with no place in town to get health care.
It is very good, yes. We didn't eat any breakfast.
Has it impacted your health care since the hospital closed?
It has. During that time, we've not had any hospital care here at all, no emergency room. I'm a strong believer in health care being available. I'm also a strong believer in that it has to be paid for, and if you can't meet your payroll or you can't pay your bills, then how can you stay in business?
Rural populations in the U.S. are shrinking as more people move to cities and suburbs. And those that stay tend to be older, often poorer, and are more likely to suffer from conditions like heart disease or cancer. But the places that would care for them are disappearing. In the last decade, almost 10% of rural hospitals closed. That means people who remain have a harder time accessing both basic and emergency care. Here in Kansas, 3 out of 4 hospitals in small towns are at risk of closure.
All right, we're going to pause right there. So I wanted you guys to take a look at that video just so that you get a sense of when we talk about rural healthcare, what kind of area we're looking at and what kind of compromises we may see. So when we look at our rural health, we're going to take a look at our PowerPoints for chapter 24. And I hope I'm sharing my screen, but I don't think I am. So we're going to take a look at 24 and what that looks like for our rural healthcare. Okay, so we have rural healthcare and migrant health. So we're talking about these communities where there's not as much access to healthcare as you might have in a urban facility. So we know that we have access to healthcare, and there's not a lot of health professionals that are going to be working in these areas due to poverty, limited access. Social isolation has plagued many rural communities. We know that we have our migrant workers as well, and we're going to take a look at those. So when we think about rural, we think about more farmland, more farm residency. We have urban areas, which are going to be our cities, our metropolitan areas, and we take a look and see that we have this donut effects, which is what's happening is people are going to more affordable housing in our rural communities. We see with our characteristics in the rural population, we have a higher proportion of whites, higher than average, younger and older, most likely to be married or widowed. We see fewer education. We see a higher rate of poverty and poorness, and higher risk for being underinsured or uninsured. When we look at our barriers for rural communities with healthcare, we have higher poverty rates, cultural and social norms about health behaviors. We have low health literacy, so we're not able to provide as much information and get that. We see limited, reliable public transportation, so they may not be able to get to their healthcare facilities. Unpredictable work hours. We see unemployment because you just don't have that opportunity like you do in a city. We have lower population density. Availability of resources is slimmer, and our lack of access to healthy foods and physical activities. So we're not going to have gyms every mile or so in a rural area. So think about that. When we know we have a poorer perception of their overall health in our rural communities, less likely to engage in preventative behaviors and more likely to have a chronic condition like heart disease, COPD. We're going to have poorer health and less likely to see medical care. And reasons for that is travel time. And we see that our ambulatory care centers are not within a close distance. So we know our healthcare providers, they live and practice in particular communities for decades. So you'll see the same health providers in a rural area and small staff to a large area because, you know, our farmlands and stuff taking up a lot of square footage, but we don't have that that rush of people going into the rural communities like we do in the urban. With maternal and infant health, we have a higher infant and maternal morbidity, higher proportion of racial minorities, and fewer specialties. So particularly at risk are going to be our women who are on our Indian reservations, our migrant workers, and African American descent. We see victims of sexual assault in the rural communities because everyone sort of knows one another, so less likely to report those kind of things, addiction and abuse. Urban children are more likely to see a pediatrician when they're ill, where rural are most likely to have a general practitioner, so maybe not go to our pediatrician so much. We have our children who are working on the farms. We want to think about our pesticides. Mental health is a big problem. We see a delay in care in the rural community, depression, high rate of poverty, geographic isolation, not a lot of mental health services. Domestic abuse, alcohol, tobacco, and drugs is not going to be reported like it is in other communities. COVID really had an impact on our rural communities, and we saw that impact. We have occupational and environmental health hazards. Like we said, these rural areas are going to have forestry, mining, agriculture. We're going to be doing our pesticides. We have a low OSHA regulation for farming and ranching. We see injuries like they're bent over all the time. You're going to see spine and back issues. We see heat stress and heat exhaustion in these rural areas. So we know that there's a lack of healthcare providers. We know public transportation is a problem. We don't have a lot of outreach services. This is something we need to work on. Unpredictable weather and travel. Inadequate attitude with the providers. Language barriers may be a problem, and care and services that aren't culturally sensitive. So know that we may have also our undocumented immigrants out here working on the farms, and so we're not going to really know about their health care and something to think about. So we said again, we have availability of services as a concern. We see incidents of TB, substance abuse, dental disease, discrimination and documentation. They don't go and they're not seen. We see mental health on the rise, chronic illness on the rise in our migrant communities. So when we talk about our considerations with migrant healthcare and the nurse-client relationship, we want to make sure we're being sensitive to their beliefs as well as looking at our own biases so that we know what our health values and practices are in our migrant community. Community-oriented nursing needs to vary by community. There's going to be a need in most rural areas for all the following: school nurses, planning services for families, prenatal care, care for individuals with HIV, emergency care services, mental health services, and those for adults. So we see community health and primary care, and these are the things we're going to be looking at: characterizing the community, identifying our health problems, monitoring our program processes, and our outcomes. Healthy People 2030 does speak to our rural factors, and they want the community to be involved and take some ownership of it and use some resources, because the more they're involved, the more they will take it into consideration. We know that we have a connection with our telehealth, so we can connect with consumers in these rural areas. We can do video conferencing, text messages, telephone services, things like that. A good area to go into in our nursing. So that about covers our chapter 24, and that's going to be our rural healthcare. I want you to think about how they have lack of services and what that will do for them and why they don't do follow up with their primary cares and things like that. It takes us right into our chapter 25, which is going to be our poverty, homeless, teens, and mental illness, our vulnerable populations. So take a look at that one when we do. So 4 groups of people that are going to represent are vulnerable. We have poor, homeless, pregnant teens, and those who are mentally ill. We have to be careful with our biases with these groups and identify their healthcare needs and barriers to each. With our vulnerable populations, we have perspectives about individuals who are responsible for their health. And maybe it's their personal beliefs and attitudes, but we need to be very sensitive to not have ours impact. Poverty and homeless affect people's health status. So we know the poorer they are, the higher rate of health concerns. We look at factors that are affecting our growing number of poverty. We have decreased earnings. We've increased unemployment rates, dwindling payments to children, increase of children born to single women, trade deficits, debt, and those kind of things. When we look at our poverty and health across the lifespan, we have a higher rate of chronic illness, higher rate of infant morbidity and mortality, shorter lifespan. So the hospital rates are 3 times more for those people with low income than those with higher incomes. And sometimes that is because they don't have a primary care physician. So the ER is really served as that. A special effect we see on women of childbearing ages with our poverty. We see adolescents as a growing poverty population, urban and rural communities both. When we take a look at our homeless population, we know our poverty can lead to homelessness. It's kind of hard to figure out how many people are exactly, but we do have some acts that we're helping with that. And we have crisis poverty and then persistent poverty, where it's going to go on over a period of time. We know here are some effects on our health with the homeless community. We're going to have, poor skin integrity, vascular diseases. We'll have HIV, trauma, mental illness. They're going to be using tobacco, alcohol, and drugs. And we see barriers to getting care. Our at-risk people are pregnant women, children, adolescents, older adults, and veterans. So it's across the spectrum here. Teen pregnancy has a significant effect on our communities. We see income, education, social support networks, and living environment is all going to have to do with that. Some healthcare services that may be available but may not be is birth control. It is confidential care over the age of 14. Factors that are, these are factors that are going to influence whether a girl becomes pregnant and the support that she gets. So we take a look at sexual activity, use of birth control, peer pressure, and we know that young men in paternity, there's a concern there with consistency. So we want to early identify our pregnant teens. Issues that we see with them is going to be violence, low birth weights and pretermers. The younger they are, you have a higher risk of that. Then you worry about their school and education needs. We would need to keep these pregnant adolescents in school so that they can not go into the poverty and the homeless community, so that they can overall take care of themselves a little better. Mental illness in the U.S. could be a whole class, but just know we have these that are at risk. We have high prevalence rates. Which levels of prevention we can look at is we can do some teaching on affordable housing, preventative healthcare systems, our needle exchange programs, our parent education, supportive and emergency housing, soup kitchen, screening for depression when we're looking at our secondary. And tertiary, we're going to support affordable houses and rehab programs. So with the vulnerable populations, we have to be really careful to create a trusting environment, show respect, compassion, coordinate networks of services, focus on prevention, and know when to walk beside the patient as opposed to developing a network support. Stop sharing that for a second. Sorry about that. So that was our chapter 25. So that's our vulnerable populations. We're going to move on to chapter 26, which they all kind of go together because this is going to be alcohol, tobacco, and other drug problems in the community. So we see that with our vulnerable populations. We see it at the rural communities as well. So we take a look at knowing that alcohol, drugs, and tobacco is going to be causing more deaths, illnesses, and disabilities than any other. Substance users not only at risk for personal health problems, but maybe a threat. We see abuse and addiction affecting all ages, races, and sexes. Alcohol abuse and addiction cause multiple health problems for adults. Every culture has beliefs about alcohol, so we need to see their attitudes by the way they categorize drugs as either good or bad. We have some substance disorders that we'll see in our DSM-5 guidelines. We have drug dependence, alcoholism. So when we take a look at drug use, we're going to talk about our psychoactive drugs and the way they affect mood and perception, how they're used for enjoyment, sometimes in recreational and social settings. So we look at our psychoactive drugs are divided into categories according to their effect on our central nervous system and the feelings that may come out of the drug use. So we also have our depressants, which are going to reduce our central nervous system, and they're going to decrease our heart rate, respiration rate, coordination, and energy. And we have higher doses lead to coma if the vital function shut down. So major categories are going to be alcohol, barbiturates, benzodiazepines, and opioids. We also have our stimulants like nicotine, cocaine, caffeine, our energy drinks, which I remember are going to make our stimulate our heart rates. So we see these drugs won't actually give you more energy, but they will cause tachycardia. Alcohol is our oldest and most widely used drug in the world. About 2/3 of Americans drink alcohol. And we know that we have a genetic and personal influence on the use of that. And we move on to tobacco, which we're working very hard to decrease the smoking in the country, but we have 16 million Americans that are going to live with a disease caused by smoking. We have our secondhand smoke, where we talked about with kids, you want to be careful with that. Chewing tobacco and e-cigarettes. One of our most widely used psychoactive drugs in the world is going to be our caffeines, coffee, teas, soft drinks, and various medications. We have marijuana, which is now becoming widely used, and it's also becoming it's becoming legal in many states. So 1 in 10 who use it will become addicted. It does have side effects, and it does have a decrease in permanent IQ, can lead to mental illnesses, and then driving, of course, and development of a fetus. Opioids is where we're at our biggest crisis in the United States. We have two different kinds. We have our natural, which is going to be our opium, morphine, and codeine. And then we have our synthetic, like our heroines and our oxycodones. We have guidelines for prescribing opioids right now, but there is regulation that's trying to help with that. We have our amphetamines and methamphetamines. So they're like cocaine, but they're going to last longer. They have a chemical structure of that of adrenaline, and are used to decrease fatigue, increase mental illness. We have methamphetamines like our meth, which is easy to make street drugs that they will use to swallow, smoke, snort, or inject. When we look at our predisposing and contributing factors, we look at the drug, we look at the individual using it, and the influence with our physical, social, and genetic component. There are genetic factors in addiction, like we said. Evidence indicates that both disorders, alcohol and drugs, are at least partially influenced by genetic factors. Environment is also going to be a contributor. If you're living among a population that's using drugs more frequently, you're more likely to do that. Children of addicts are 8 times more likely to develop an addiction than children of non. So when we look at our primary preventions, we're going to do our harm reduction. We're going to be teaching no drug is safe and any can be abused. We're going to be helping people to make informed decisions so that we have less harm. With our secondary prevention, we're going to be assessing for alcohol problems, drug testing, high-risk groups like our adolescents, our drug users, use of illicit drugs, and our family involvement. And then with tertiary, we're going to do a lot of support groups like AA and NA. We're going to have smoking cessation programs, addiction treatment, and detox. Nurses' role is we want to be really careful about what we know in the community, what resources are available, develop some programs, and we are in an ideal help to assist with this rehab and for prevention for both the addiction, the addicted person, and the family. So that covers our 3 chapters for this week. Know that I want you to be familiar. You will have an assignment week 9 with vulnerable populations, and you're going to be picking a vulnerable population in your community and doing some research on that. See you guys next week. Take care.